Thank you very much. It was a great privilege to give a lecture, and I don't know how to qualify the privilege of giving 2 lectures. I'd like to disclose that I have been an investigator for AbbVie, the visual trials, sponsored by AbbVie, an investigator, and I also helped in the design of the trial. So I'm going to talk about the new warfare in inflammatory diseases and applied to birdshot chorioretinopathy. If I make a military comparison, when we were in World War II, the bombing was, there were carpet bombing, and the bombs were not really targeted to their, they were dropped, but they were not always right on target. What has changed with biologic response modifiers is that the equivalent, military equivalent to laser-guided missiles that we, in these complex drawings of the way that the immune response works, we cannot, unspecifically target the whole field, but we can specifically, using monoclonal antibodies or fake receptors, target one given pathway that is implicated in the immune response, which is a very, very significant change as opposed to the old times when we were using glucocorticoids that had an indiscriminate effect on the whole mechanism, cell mechanism yielding inflammation. And as much as I hate these complex drawings because I can never remember which cell elaborates which interleukin, we know that there are certain pathways like the IL-17 pathway, the TNF-alpha pathway that are critical for triggering inflammation, and that we can block specifically with these new agents this or that pathway that is important in the inflammatory diseases. So there are several categories of agents that fall in the biological response modifier definition. Ones are the monoclonal antibodies, interferons, and immunoglobulins. And I'm going to show you how these agents have been used or are being used in birdshot. First, a short summary of how these antibodies are labeled. There is a variable prefix. Then when the target is the immune disease, as all drugs that are used in birdshot, you have Li. And then you have, when the source is human, humanized, chimeric, or mouse, you have different codes. And then because they are monoclonal antibodies, the suffix is the same. Hence, the complicated names that we have in infliximab, for instance, you'd follow that it is targeted to the immune system, chimeric, and then the mab suffix. So this is what has been reported in the literature regarding patients with birdshot that have been treated with biologic response modifiers. The largest series by far has been published by this group here, and I feel a bit difficult for me to comment on Dr. Foster and his teamwork on infliximab that has been used reported for 22 patients. 22 of them had birdshot, and it was just published this year, and I'll show you the abstract of the article. If you look at all the other published data, the number using monoclonal antibodies are much smaller. There has been tocilizumab, which is an IL-6 receptor blocker, applied on a total of 5 patients with posterior uveitis, among which 3 had birdshot, and that is the team by Alfredo Adan from Barcelona, Spain, published this year. Rituximab, 1 patient, published this year in 2013. Interferon alpha, publication on 6 patients, 2 out of 6 having birdshot. Daclizumab, which is an humanized anti-IL-2 receptor, anti-CD25. Total number of patients, 5. 2 had birdshot. That was back in 2008. And that's a different story. There is the group from Foucluong and the Petit-Salpêtrière group that have used largely intravenous immunoglobulins. So this is Dr. Foster and his team article that was published this year on infliximab treatment of patients with birdshot chorioretinopathy. 22 patients, 44 eyes were treated between 2005. That was really the beginning of infliximab in June 2012. And in their publication, and please correct me if I'm wrong, but what was shown is really effectiveness, and you can see that at 6 months and 1 year, more than 90% of the eyes had visual acuity that was better, 20/40 or better, and the number of adverse events was the usual that you observe with this kind of treatment. So it really, the data suggested as the conclusion was infliximab was effective for controlling inflammation in otherwise treatment refractory causes of birdshot. And again, I'd like to stress that these patients were the most severe cases. They were labeled refractory to conventional IMT, as Dr. Foster pointed. The other series are really on a much smaller group of patients. Here, you can see that the daclizumab, the anti-IL-2 receptor, 2 patients with birdshot, and again, a report that the high-dose daclizumab could reduce inflammation in active patients, but again, you can see that this was really in a small series of patients. Rituximab, rituximab, that was a bit more surprising. Rituximab is a B cell, is targeting B cell, and from what we suppose of birdshot, it's mostly a T lymphocyte disease. But then, with these treatment that has been used, for instance, mostly in disease like Wegener's granulomatosis, you can see that you can have a complete eradication of peripheral B cells. And on this case report published by a British team from the Moorfields, the patient had a control of his inflammation and best corrected visual acuity that was maintained at what would be the US equivalent of 20/20. I'd like to stress that as has been reported in some other biologic response modifiers, we know that we can have paradoxical effect, and we published 3 years ago this article in patients that had Wegener's, which is a disease that doesn't yield macular edema or indirectly when there is posterior scleritis, but we observed 2 patients that had Wegener's, no intraocular involvement, and that developed paradoxical macular edema. So sometimes with this agents, we can have paradoxical effects, as has been shown for another anti-TNF, with etanercept, which nowadays is not the first choice of biologic response modifiers when we decide to treat patients with that category of molecules. Tocilizumab which is an anti-IL-6 receptor, 3 patients with birdshot, and again, the data that reported showed that it suggested that tocilizumab could be effective for treating CME in otherwise treatment-refractory cases of uveitis. Interferon alpha, that's another story. It's not a monoclonal antibody, and if we remember the pathway, interferons are usually effective in diseases that are thought to be viral triggered or triggered by infectious agents. It's used, for instance, in some cases of hepatitis to control viral replication. So it's a bit of a paradox to think that interferon, which is birdshot, that is an autoimmune disease, boosting the immune system as with interferon could be effective, yet this team from Nantes has showed that in a series of patients that had uveitic macular edema, 2 of them being birdshot, the treatment seemed to work to control uveitic macular edema that was otherwise refractory to steroid or immunosuppressive drugs. Immunoglobulins, the Pitié-Salpêtrière team, under the guidance of Phuc Luong, has been pioneering this treatment for more than 10 years now. And in this paper, published in 2002, 18 patients were followed prospectively. And again, I hate to comment on somebody else's work present in the room, but the conclusion was that the treatment was effective and well tolerated and could be a therapeutic alternative for the treatment of birdshot. So this is what's been published so far. Clinicaltrial.gov is a fantastic site that can allow to really know what's ongoing in the treatment that are using any kind of therapy, including biologic response modifiers. And this is when I checked 1 month ago what were the treatment trials that were enrolling patients with non-infectious posterior uveitis and what were using biologic response modifier. You can see that here with the ustekinumab, which is a human anti-IL-12 and IL-20/30 antagonist, there is a phase 1/2 trial, and it's a single center study recruiting 5 patients. And they must have active intermediate uveitis, posterior uveitis, or panuveitis. That means that this trial can enroll patients with birdshot. Tocilizumab, there is an ongoing single center trial. A randomized trial. It's not yet recruiting, but it's going to be single center, and they're planning on recruiting 36 patients, and their inclusion criteria will allow patients with birdshot to be included. The large trials ongoing are the ones that are sponsored by AbbVie, and there are 2 trials called the Visual 1 and the Visual 2. These are multi-center worldwide trials, including 200 patients with active uveitis or 200 patients with otherwise quiet uveitis, active intermediate posterior and panuveitis, and the outcome measure is going to be the time to treatment failure after corticosteroid taper. That means that they're including patients that are treated by corticosteroids, and then the adalimumab is started, and the corticosteroids are stopped, and the trial monitors when the disease becomes active again. Of course, if the disease becomes active, this is a placebo-controlled trial. The patient is taken off the trial and is offered to be included in another trial called Visual 3, where they are sure to receive the test drug. This is a similar trial that is targeting quiescent inactive uveitis, and where the patients are switched to Humira, adalimumab, and again, when they are switched, we monitor what's going on in terms of treatment failure and to see whether they are doing better or worse than when they were on other drugs. The other major trial are trials that I understand are guided from this place here, which is a multi-center trial, again for both an active uveitis and the other trial on controlled uveitis, multi-center, 300 patients with targeting, the XOMA gevulizumab trials targeting the IL-16 pathway. One trial that was targeting anti-IL-17 was withdrawn after bad results on another form of uveitis triggered by Behçet disease, and after although all the experimental data suggested that was a very interesting pathway, the preliminary results were not good enough, so that the firm manufacturing the anti-IL-17 went further, and they temporarily at least withdrawn the trial. Lastly, there's going to be last trial here with tocilizumab, and which is targeting the IL-2 receptor, and it's going to be a phase 2 randomized double-blind trial, but it's going to be only in 5 patients. And again, all these trials have the potential to enroll patients with birdshot. So, given all this, when should a patient have a treatment that onset with biologic response modifier? Well, the answer to that question is simple: when we think that the benefits are going to be greater than the side effects of the drug, which is true for biologic response modifier, but which is true for any kind of therapy. So this has to take into account the side effects, because there is no such thing as an effective drug, whether corticosteroids, classical immunosuppressants, or biologic response modifier. There is no effective drug that doesn't have a side effect. And we know that biologic response modifiers have, and especially anti-TNF, have anaphylactoid-type reactions, fever, chills, headache, dyspnea, chest pain during the infusions. We know that that the patients that are on this kind of drug can have more severe infection, and tuberculosis is a real concern. At the beginning, when these drugs were used in rheumatic disease, there were some cases of fatal tuberculosis. Now it's much more controlled. The patients are regularly tested, and if there is any doubt that the patient has latent tuberculosis, the patients should be treated before they can benefit from a treatment by biologic response modifiers. Hepatitis B reactivation had been shown. Drug-induced lupus, demyelinating disease has been seen. Cancer and lymphomas. And the facts are that nobody has been treated yet for several decades by these agents, so we don't really know what the long-term effects are. Also, they're probably not worse than the effects that we have under other lines of treatment that are acting in the immune system. So given that, what are options for therapy in birdshot? Well, I agree with all the speakers that have said this morning that if you decide to treat, and again, perhaps not all patients need to be treated, but if the patient have inflammation that is threatening their vision, they should be treated. And prednisone alone is usually not the good choice. And the treatment should be associated with corticosteroid-sparing therapy, which can be classical immunosuppressants, but nowadays could be biologic response modifiers. Should biologic response modifiers being used here only if classical immunosuppressants have failed, or should they be used as first-line therapy? We cannot answer this question now, but if we follow the lines of what our colleagues in rheumatology are using for other diseases affecting autoimmune diseases, usually they're second-line therapy, they're not the first line here. And I think that this option B, treatment from the onset with cortico-sparing therapy, is much better, has been said by other speakers before, than this approach, which would be treating by corticosteroids alone and only introducing this kind of agent when there is an inflammatory rebound. Because usually, if you do that, the total dose of corticosteroids, it's much greater than if you have started the immunosuppressant or the biologic response modifiers from onset. Should we associate both the immunosuppressant classical and the biologic response modifier? That is still an unknown question, but certainly in the field of rheumatology, many of our colleagues think that we will have less long-term effects, less immune reactions if both treatments are associated. So we're really at the stage where we're still a bit of the sorcerer's apprentice. We don't know yet. These drugs are very new. Again, the largest series in birdshot has been Dr. Foster's populations with 22 patients. We haven't used these drugs for 10 years. Does that mean we're totally crazy? No, it just means that we're climbing the ladder of gathering evidence-based data. Let me just reflect with you on these levels of evidence. And these are the levels of evidence as stated by the Center for Evidence-Based Medicine in Oxford, in the UK. 1A is when we have available systematic reviews with homogeneity of randomized controlled trial. 1B is we have individual randomized controlled trials with narrow confidence interval. 1C, well, there are all or none randomized controlled trial, and we go down like this: systematic review of cohort studies, individual cohort studies of low or low quality, outcomes research, systematic review with homogeneity of case control studies, individual case control studies. These are studies where you're controlling patients that are treated versus patients that are not treated. Then you have case series, or poor quality cohort and case control series. And the lowest level of evidence is, I come here and I tell you, well, this treatment is better than another, but I haven't really published a long-term follow-up. Well, we're still here on that ladder. It doesn't mean we're not doing our job. It means that birdshot is a very rare disease, and gathering this kind of evidence in ophthalmology is possible it's easy for diseases that are very prevalent, like glaucoma, that are rather simple to monitor with rather homogeneity of the patients. But in birdshot, with all its heterogeneity being a rare disease, we're slowly climbing that ladder until the results of the large series that have been mentioned, the large ongoing trials are available. What we can rejoice about is that after having very much been an orphan field of ophthalmology, what has happened in the last decade is that at long last, the pharmaceutical industry has taken interest in uveitis, and that will benefit all kind of patients with uveitis, but especially the birdshot, which is a birdshot chorioretinitis, which is a long-term disease, which is kind of the model posterior uveitis. So in conclusion, we know that biologic response modifiers are effective. That has been demonstrated over and over in each of these case studies. Are they more effective than immunosuppressants? Perhaps, but we don't have the evidence-based data yet to be able to strongly make the case for being more effective. We suspect that they are more effective in diseases of the articular disease in rheumatology. They've been shown to be more effective, but we don't have yet the evidence to absolutely say, yes, we are sure that they're more effective. We suspect so, but we're not sure. Do they have less side effects than immunosuppressants? They have different side effects. But for these diseases, for these treatment categories, we have several decades behind us to really assess what the risks are. For these, we don't really know yet what happens after several decades. What are the subgroups of patients that should benefit? Should it only be the refractory cases, the patients that are not controlled under immunosuppressants? We don't know yet. What should be the optimal treatment duration? One of the problems that our colleagues in rheumatology are observing that in diseases such as rheumatoid arthritis, the treatment by biologic response modifier, at least some of them, are suspensive, but when this treatment by biologic response modifier is stopped, then rebounds are observed. So it could be just a suspensive, but not a curative effect. And that could be a distinction between some immunosuppressants like cyclophosphamide that are used in some very severe other autoimmune diseases that sometimes, not always, but sometimes have a curative effect. So we're there in 2013. There is a large dose of empirism in our decision. In some areas of the world, at least, cost is going to be an issue because these treatments are usually extremely expensive, and we're slowly climbing that ladder towards an increased level of evidence-based data to better determine our choices, what we can offer the patients with birdshot chorioretinopathy. I thank you, and I thank all my colleagues working with us in our birdshot team.